happens in a complete mole is that about 85% of patients, there will be an empty ovum that is fertilized either by a haploid or diploid sperm, leading to a formation of a diploid cell with 46XX cell type that is formed. So that is the pathophysiology of complete mole. Some percentage, about 15%, can be seen in heterozygous form, where a diploid cell is fertilizing an inactivated ovum, and then you get paternal chromosomes only, leading to a diploid cell with 46XY, 46XY. So this one is less common compared to the previous one. And then in terms of pathophysiology of a partial mole, here what happens is that there is disperm fertilizing a normal ovum, and the result being a triploid cell with both maternal and parental chromosomes. So what's different between the two is that choriocarcinoma is purely androgenic, whereas partial mole is comprising of maternal and paternal chromosomes. Now, in terms of risk factors, as I've mentioned, extremes of age are thought to be a risk factor, and it's believed to be because of abnormal oocyte maturation and gametogenesis at the extremes of age. Molar pregnancies, it is said that the more molar pregnancies you've had before, the higher the risk of developing another molar and possibly GTN. There's also a genetic susceptibility to getting the condition, as I mentioned, a mutation in the maternal effect gene, which is your NLRP7 and KHDC3L. So what happens here is that there's defective maternal imprinting, thus resulting in abnormal trophoblastic proliferation despite parental genetic contribution. Other factors like socio-economic and environmental factors and nutritional factors have been implicated. Oral contraception, some studies do suggest that it may be associated with partial mole, but evidence is weak and it's not fully understood. There's also other risk factors like ethnicity and dietary deficiencies. Now, this table is just illustrating the differences between the two types of high DT4 mole. So in terms of histology, pathology, and cytogenesis, as I mentioned, complete mole is mainly paternal origin, whereas partial mole consists of both maternal and paternal origin. Complete mole is diploid, whereas partial mole is triploid. And with complete mole, you get there's more likely predisposition to getting a post-molar GTN, whereas with partial mole, the incident is rare. And then there's a newer staining technique, which is your immunostaining, and it's said that with partial mole, it's positive for P57, whereas with complete mole, it's negative. So this is basically to help you differentiate once you've taken the specimen for histology to know whether it's complete or partial mole. And then in terms of clinical presentation, I must stress that because of widespread use of ultrasound, now the clinical presentation is limited to vaginal bleeding, but you may still have some less common presentation like your excessive uterine size, preeclampsia, and it's important to evaluate these patients, more especially if they come early with preeclampsia, to exclude these high DT4 mole. And then they may also present with hyperemesis gravidarum and hyperthyroidism because of high beta HCG. So the beta subunits of HCG will mimic the TSH activity, thus resulting in increased thyroid hormone production. And this is important because it carries the perioperative risk. So surgery or anesthesia needs to know because they can precipitate a thyroid storm, which is life-threatening. Some patients can present with a thicker luteal cyst, typically because of a high HCG, and it is said that it's usually above 6 centimeters. You don't need to do anything with thicker luteal cyst. They usually regress But if the patient presents with pain or compressive symptoms, then you'll have to treat. And some patients may present with passage of vesicles. These are some of the rare symptoms that you may find, particularly if it's a GTN with metastasis, or if they present with vomiting and there's electrolyte disturbances, they may have seizures or even confusion. Now, in terms of investigation, the bedside investigation obviously is your urine HCG to check if indeed the patient is pregnant. You also need to exclude all the other symptoms that they may present with, so you assess the patient fully. But the main or key diagnosis is your ultrasound, which will help in knowing whether there is a high DTD4 mole or not. So this is just a picture that is showing a picture of high DTD4 mole and thicker cyst. So the first image on the right is showing the classic previously known as snowstorm appearance, where there is mixed echogenic and vascular pattern instead of the normal placenta. And then on the left, it's a thicker luteal cyst, which is shown, it's usually bilateral. The ovaries will be enlarged and multiloculated. In terms of biochemistry, you do your quantitative beta HCG, which will quantify the amount of beta HCG. It's usually markedly elevated in complete high DTD4 mole than with partial mole. So there's other variants of beta HCG that you need to take note of, which can also tell you about the predisposition to a gestational trophoblastic neoplasm, which is your hyperglycosylated HCG, your mixed or your nickel type HCG forms. And then other investigations that you can do is your full blood count to assess for anemia, because we said the patients are presenting with bleeding. You may do a clotting profile if they're bleeding excessively and they're going into DIC. You do your renal function test and your LFTs if you suspect preeclampsia, and then your thyroid function test, and you need your baseline booking blood, and also you cross-match these patients because they may need transfusion. Now, in terms of imaging, these are done as baseline to exclude metastasis should you suspect a GTN. So you can do a chest X-ray, rarely CT or MRI, only if there is a local invasion or metastatic disease. And then in terms of management, counseling is very important for these patients because it actually helps them understand what's going on and for better follow-up. So there is no role for medical treatment except if it's a partial mole with a fetus that is large enough to consider medical termination, or when surgical evaluation is not feasible. So FIGO advocates for suction curettage as the cornerstone management for molar pregnancy, followed by HCG monitoring. So before you take patients for suction curettage, they need to be preoperatively assessed. So you need to exclude all the clinical features that I said they may present with and correct whatever abnormality you have, more especially with hyperthyroidism, because I did say it can precipitate to thyroid storm, which has detrimental effect, and the anesthetists need to know about it. And you need to give a beta blocker if hyperthyroidism is suspected. Now, the issue around prophylactic chemotherapy, they're saying that it is used to prevent persistent trophoblastic disease. However, it's controversial because about 20% may develop persistent disease. And according to FIGO and some European guidelines, they suggest that prophylactic chemo is not routinely recommended except in high-risk high DTD4 mole. Now, how you perform the suction curettage, obviously you do it to spare fertility. So you use a 7 to 12 millimeter suction cannula. And if the patient is above 14 weeks, you place one hand on the fundus, you massage the uterus to prevent uterine invasion and hemorrhage. And it's recommended that you do it under ultrasound guidance to avoid incomplete evacuation. And you always avoid sharp curettage because of the risk of perforation, Asherman syndrome, and myometrial retention of trophoblastic tissue. You also need to ensure that you've got blood available, particularly if the uterus is 16-week. And then with the issue regarding oxytocin, FIGO recommends that you start oxytocin at the onset of suction curettage and you continue it for several hours post-evac to enhance contractility. And once you've evacuated, you send specimen for histology. Now, I didn't go deeper into all the complications that you get following suction curettage, but these are some of the immediate complications that you may get, which is hemorrhage and perforation. So if the patient is bleeding, you need to resuscitate the patient thoroughly, give uterotonics. You can put a tamponade after you've ensured that there's complete evacuation, but if they are bleeding beyond the tamponade, then you proceed to definitive management where you open and you can do uterine artery embolization or ligation, and the last resort will be your hysterectomy. In terms of perforation, if you suspect that you might have perforated, you stop, you assess for hemodynamic status, you do an ultrasound to check if there's any free fluid in the abdomen, and if there is, then that will prompt you to do an open laparotomy to repair. And if you suspect that there's dissemination, then you have to consult gyne-oncology. Now, the role of surgery in these patients, obviously, it's patients who are no longer fertility desiring, patients who are having a uterus that is above 16 weeks. If they're having persistent bleeding, the advantage is that it offers permanent sterilization and it also reduces the risk, the need for chemotherapy. And then usually, because our patients are young patients, so you spare the ovaries, you leave the ovaries behind, but you still need to follow up their beta HCG post operation. I've already mentioned the management of thecal luteal cyst. It's only indicated when it's symptomatic, otherwise it regresses. So what you do is aspiration. You can do it under ultrasound guidance or laparoscopic decompression. The issue of repeat suction is generally not recommended, only for selected patients and after they've been evaluated. So only if you had done the suction curettage and you didn't use ultrasound, and after you do the ultrasound and it still shows retained products of conception, then you can do it, or if the HCG is less than 5,000. Now, the issue of coexisting mole. This is when there's one fetus coexisting with a complete mole. So it's a rare incident, but you need to counsel the patient thoroughly because of risk of persistent GTN is higher. And then expectant management is possible if the normal fetus is viable and the mother is asymptomatic and they're completely not having complications. And then that means that you need to frequently monitor these patients. You only consider termination if there's maternal complication or if the fetus is having anomalies that are not compatible with life. But they can reach live birth in about 40 to 60% with intensive monitoring. Now, if the molar is an ectopic, the management is surgical excision like you do with any ectopic, but then there still needs to be a strict follow-up of HCG because of the likelihood of persistent disease on it for chemotherapy. Now, I also mentioned that you need to do your booking bloods because if a patient is Rh negative, there may be alloimmunization. So you need to treat the Rh negative women. Typically, you use 50 to 300 micrograms, depending on the gestational age and the risk. Now, in terms of follow-up for these patients, you do weekly HCG until normal for 3 consecutive weeks, and then monthly for 6 to 12 months post-evacuation. So the rationale here is to detect persistent disease and treat accordingly. Now, coming to persistent mole, there's some risk factors that may predispose you to a persistent mole, more especially patients that are above 40, extremes of age or previous molar, or if there's histology that shows a complete mole, because we've said that complete mole because of androgenic type, then it carries a higher risk to progress to GTN. Also, if there's high mitotic index or cytological atypia, because it suggests aggressive proliferative potential. Now, how do you diagnose persistent mole? According to FIGO, if there is beta HCG plateau, you have 4 values about 1 week apart, showing a plateau over 3 weeks. Or if you have beta HCG rise of 3 values that increase over 2 weeks, or if you have a histologic diagnosis of choriocarcinoma after you have sent the specimen for histology. Now, indications for chemo obviously would be if you meet the criteria for persisting mole, or if the metastatic disease without primary site with elevated beta HCG and pregnancy has been excluded. And then now coming to gestational trophoblastic neoplasms. So the different type, the striking feature here is that with choriocarcinoma, it's purely from the trophoblast, whereas the other ones are from the intermediate trophoblast. And if you were to compare choriocarcinoma and the hydatidiform mole, is that choriocarcinoma has no chorionic villi, whereas the other forms of GTD, or which is your hydatidiform mole, they have a chorionic villi. Choriocarcinoma is highly malignant with a rapid spread, but it does respond well to chemotherapy. And then the other classification that has been added, which is a placental site nodule, it's an incidental finding, it's benign, but it can progress to ETT and PSTT. And then PSTT and ETT are quite rare and they are less chemosensitive. So the mainstay treatment for these two types is surgery, and they can be quite aggressive. Now, how do you investigate your GTN? Obviously, you send the specimen for histology and molecular genetics, and then ultrasound still remains your key diagnostic tool, and you also do your HCG. Now, this is an ultrasound picture that shows the features of GTN. So you may see heterogeneous intrauterine masses with multiple cystic spaces. There may be marked internal vascularity on Doppler with low resistant flow. And also there may be evidence of a myometrial invasion. Also, because of very high beta HCG levels, they will present with bilateral decalutal cysts. These are just the investigations that you need to have for a patient that you're suspecting a GTN to exclude malignant metastasis. So a chest X-ray is number one to check for lung metastasis. But it is important to note that if there's macros or nodules, like small nodules that can't be detected on X-ray, CT chest may be indicated. It's not routinely done, but it's much more sensitive for detecting small nodules. And then other things that you can do a liver ultrasound and brain imaging. You can do MRI. It's preferred, but we don't readily have MRI available. So you can do CT if you don't have MRI available, if you're suspecting brain metastasis. Now, in terms of FIGO staging, you have stage 1 to 4, where stage 1 is confined to the uterus. Stage 2 is outside the uterus, but it's limited to the genital structures. Stage 3, it extends to the lungs with or without known genital tract involvement. And then stage 4 is all other metastatic sites. And then there's also a scoring system that risk stratify patients that FIGO came up with. So it is looking at things like age, antecedent pregnancy, the interval from index pregnancy, your pretreatment HCG, sites of metastasis and previous chemo. So you then score it from 0 to 4. Any score less than 6 is considered to be low risk, and any score above 7 is high risk. So this is just the table that is showing the commonest sites of metastasis. So pulmonary is your commonest site, and your brain metastasis is about 10%, and patients may present with focal neurological deficits. Now, in terms of management, counseling plays a very essential role. It's important because it encourages compliance and also follow up. So the options that you have, chemo is your mainstay, but you may still do surgery in selected cases, and you also need to consider fertility sparing in fertility desiring patients, and there is some role for radiation. Now, according to the risk stratification, as I've said, your low risk is your figure stage 1 to 3, with a score that is less than 6. Usually these ones, you treat them with a single agent chemo. It can either be methotrexate or actinomycin D. It's important to note that a score of between 5 to 6 has a higher risk of drug resistance. And then high risk score is a score is staged as stage 2 to 3 with a score of more than 7 or a stage 4. So these ones, you treat them with a multi-agent chemo. You may add surgery or radiotherapy depending on whether you've got brain metastasis or not. And then with ultra high risk, it is a stage, WHO stage of more than 13. This one often requires an aggressive multimodal therapy. So before patients are given chemo, you need to wake the patients up, and they need to have the baseline investigations, and you need to correct any abnormality that is there. So these bloods are essential before you start chemo. So patients need to have your baseline bloods. If HIV, they need to have the CD4 and viral load. You also need to type and screen, counsel the patient about contraception, and you need to have the ultrasound, chest X-ray and abdominal ultrasound. And also it's important to stage and score the patients correctly, because then you know which treatment to go for. And also there must be consent for blood transfusion. And then with regards to a low risk GTN, as I mentioned, you can either use methotrexate or actinomycin D. The methotrexate that is commonly used is the 8-day regimen, where you give 50 milligrams on day 1, 3, 5, and 7. You alternate it with leucovorin, which is your calcium folinate. You need to ensure that you have bloods and you do your HCG before each cycle, after each cycle. And then you can alternate with another alternative methotrexate is the 8-day regimen. This one is for methotrexate resistance or intolerance. And the other two, they're not commonly used, the weekly regimen or the infusion. You also have actinomycin D, which you can opt for, which the commonly used one is the 1.25 milligram per meter squared every 2 weeks. And then you continue until HCG normalizes for 3 consecutive weeks. Then you give 2 to 3 consolidation cycles. So consolidation cycle is given to prevent relapse. It is also important to note that actinomycin D may cause alopecia, which you also need to counsel your patients on. With methotrexate, the common symptoms that you may have is stomatitis, conjunctivitis, and fatigue. There's a randomized trial and meta-analysis that was done that shows that actinomycin D carries a higher remission rate than methotrexate, and actually most centers are moving towards using actinomycin D for low-risk GTN. It is superior in efficacy with a complete remission rate of 96%. So what happens now in low risk group if they are failing either the methotrexate or the actinomycin D? For instance, the HCG plateaus or rises after 2 to 3 cycles. So you give another single agent regimen depending on what you started with. And then if still there's failure, then you can escalate to a multi-agent chemo, or there's newer immune checkpoints that have been set to work, more especially if you have used methotrexate and it failed, which is avelumab. And then hysterectomy in these patients is another option, more especially if they've completed family or they have a localized disease. And they may reduce the need for prolonged chemo, but it is also important to do HCG surveillance, and adjuvant chemo often is not required. And now coming to the high risk GTN, the WHO stage score of more than 7 or stage 4 disease, the mainstay treatment is multi-agent chemo. So here you give the Emaco, which is your etoposide, methotrexate, atinomycin, D-cyclophosphamide, and vincristine. So here the cure rate is about 80 to 90%, and approximately 20% do not achieve complete response with the first-line Emaco. So they may require salvage therapy, which we will look at. Some of the poor prognostic features with the high-risk GTN is if they have brain mets, or if they have a very high initial HCG, or an antecedent pregnancy of more than 48 months. Now, this is the regimen that is often used. You don't give it at a go. So on day 1 and 2, you give the EMA part of the Emaco, and then on day 8, you give the COF, which is your vincristine and cyclophosphamide. This is to not cause bone marrow suppression when given at once. And then in terms of the ultra high risk, which is a score of more than 13, you don't start with Emaco at first, because it may be too toxic, and it may cause tumor lysis, hemorrhage, and metabolic acidosis, and organ failure. So what you do here is a stepwise approach. So you start with gentle chemotherapy, which is your EP, etoposide, and cisplatin on day 1 and 2 for 1 to 3 weeks. And then you can, once they are stable, you can escalate to either Emaco or EMA-EP. And if you suspect there's brain metastasis, FIGO recommends that you increase the methotrexate dose to 1 gram per meter squared to allow the drug to cross the blood-brain barrier. Some centers may add intrathecal methotrexate at EMA cycles, or you can give brain radiotherapy. So this is what we use in our setting. For low risk type, we give actinomycin D weekly for 2 weeks until beta HCG is negative for 3 weeks. You give it with a dexamethasone and ondansetron for the side effects. And then for the high risk group is the Emaco over 2 parts, day 1 and day 2, and then the core part of it on day 8. And then you also pair it with ondansetron and leucovorin and dexamethasone. And then for the ultra high risk group, they also follow the gentle induction, where you give the etoposide and cisplatin before you can progress to Emaco or EMA-EP. And then this is the salvage therapy for patients that are failing any treatment, first-line treatment for all the different groups. So you can either give EMA-EP, or you can give TE-TP regimen, or you can give the bleomycin-based regimen, or the carboplatin-based regimen. There's new studies on immunotherapy, which is your anti-PD-1, which shows promise in terms of treating resistant GTN. So these ones also spare women from toxic multi-agent regimen. So how these work is that they stimulate the patient's own immune system to destroy tumor cells by releasing a block that is caused by PD-1 proteins on those receptors, thus allowing the T cells to fight off cancer cells. Now, the role of surgery in GTN is obviously if there's life-threatening hemorrhage in different sites, if there's a localized or drug-resistant disease, like I mentioned with the placental site trophoblastic tumor and epithelial trophoblastic tumor, because they are less chemosensitive. But if there's diffuse disease, then fertility preservation may not be feasible. Some of the indications for fertility preservation, most of our patients are young patients, and they still require fertility, as if it's a low risk score or the other subtypes of your GTN. And then depending on where the bleeding is coming from, you can do a wedge or myometrial resection. If it's from the liver, you can do a resection, or if there's brain mets, then you can do neurosurgery. So contraindications to surgery, obviously, it's if it's a diffuse disease, it's an advanced stage, or a patient has completed family, or they're not desiring fertility. Now, in terms of radiotherapy, there's limited role in GTN. It's only considered in patients with brain metastasis, or it's usually an adjunct to chemotherapy. So the survival rate is quite good with these cancers. Overall, it's approaching 100% actually. Low risk is about 97%, and high risk is about 79%. So in terms of contraception, it is recommended to avoid pregnancy during follow-up. And the contraception that can be used is your hormonal contraception, your oral contraception. But in our setting, we give the injectables because some patients forget to take treatment every day. So you can also do a barrier method. But what should be avoided is intrauterine devices because of risk of perforation, bleeding, infection, and then with regards to fertility issues, after GTN, majority of patients who wish to conceive are able to do so. Menstruation typically resumes in about 80 to 90% of patients, especially if they are treated with low-risk agent. Multi-drug, your Emaco, can temporarily cause amenorrhea, but it is reversible. More especially if it's given at high doses, your cyclophosphamide can be gonadotoxic, but it is usually reversible. And then the rates of live birth are high, and bed obstetric outcomes are generally similar to the general population. The risk of subsequent molar pregnancy is small, but evaluation in first trimester is usually recommended. And then in terms of survivorship issues, there's a large cohort of about 1,900 patients at Charing Cross by Salvage et al. That was followed up for 17 years, which showed that EMACO is associated with elevated risk of menopause, whereas methotrexate has a low risk. And then site-specific elevated risk of secondary cancers like leukemia has been observed, more especially with EMACO, but overall risk is similar to comparable population when using methotrexate. In terms of follow-up, you do serum HCG monthly for at least 12 months after remission. And then longer follow-up is recommended for ultra-high risk group. Contraception must be given, as I've mentioned. And then there's these GTD centers that it's being recommended for optimal management of this disease, and it comprises of a multidisciplinary team of gynecologists, gyne-oncopathology, and laboratory facilities. So in conclusion, updated FIGO criteria improves precision and outcome. It also prevents over-treating and improves survival of high-risk GTN. Actinomycin D is preferred for better remission in low-risk GTN. And future advances will likely focus on individualized treatment guided by molecular profiling, fertility preservation, and improve access to GTD care globally, particularly in low resource settings. And conservative surgery has been prioritized to maintain fertility. And the newer techniques of diagnostics like your P57 staining, which is positive video partial mold, has been included. And the other emerging studies, which is your immunotherapy and targeted molecular therapy, has also been implemented and is showing promise. Thank you.
Thank you to Dr. Mahdi. She was under big pressure, but she performed very well, excellent presentation, and the slides were up to the mark. But just as an overview, GTD actually is encompassed GTN, and the separate classification actually helps you to target which group of patients from benign moles to malignant moles so that they are directed to the right unit and they are all maintained in the same place. Medical therapy in terms of chemotherapy is the mainstay of treatment. And most of the literature will only target this in terms of your benign moles and your malignant mole. So in malignant moles, you're looking at MTX was the mainstay of treatment until this further study has come out to show complete remission rates that were higher with actinomycin D. So most units now have moved towards the use of actinomycin D as first line. The EMARCO second line remains with the higher risk FIGO score of 7 or more, and it's a multimodal chemotherapy regimen. Then the often question that is asked all the time is the role of surgery. And surgery is, there is a role for surgery, and usually it is not in the acute setting. Because as you monitor these patients in the oncology unit with the follow-up of beta HCG values and the surveillance, you'll be able to pick up those patients that are getting recurrent moles or invasive moles, moving towards invasive moles. And these patients are offered a hysterectomy electively. The acute setting is what we used to. And the question that are always asked is, what is the role of surgery in the acute setting? And usually it's obstetric severe hemorrhage. So these patients need to be counseled very well with the pros and cons of preservation of fertility. And emergency hysterectomy sometimes can lead to a poor outcome, poor mortality. So you need to be quick with these patients in terms of what surgical options have you got. And previously we've been encountered patients like this where people will do an open laparotomy and only to diagnose an invasive mole or an advanced choreo. And patients will demise because of severe obstetric hemorrhage and the complications thereof. So what's reported in the literature is hysterectomy as your final surgical maneuver. But we had a patient some time ago, if people remember, where a patient was in the unit of oncology and basically was counseled that she's now progressed from GTD to GTN, with now being diagnosed as an invasive mole. So the desire for fertility for this patient basically left the oncology unit, and she then visited other sites, not giving a full history. And in those days, it was the KZN numbers that we looked at and to try and track patients in the oncology unit. So this patient basically fell pregnant and went to 3 centers, Mahatma Gandhi, Addington, and ended up in Prince Msheni. So when she was managed in all 3 centers, she was managed as a miscarriage, and all 3 centers basically did an evacuation until she presented about a month later from the last unit and presented with AUB, with a cervix that was hard. People were actually doing a speculum trying to work out what the pap smear results in. And this patient here actually, she gave histories that, and she concealed the fact that she was an oncology patient. So it was an invasive mole. Only thing to be found out was that somebody did a urine pregnancy test, and the pregnancy test was negative as usual. The beta HCG was very high in the millions, and she was a choriocarcinoma. So the chest X-ray then picked up that this patient here had cannonball lesions in the lungs, and then somebody decided to do a blood test and found that the beta HCG was very high. Anyway, she went to the oncology unit, and when they had to open this patient up because of severe obstetric hemorrhage, she actually died on the table because it was uncontrollable. So most of the management plans is more electively, and we have to consider things like uterine artery ligation, internal iliac artery ligation, and hysterectomy. So you are forced in these cases, but sometimes for patients, it's a difficult thing with fertility. So fertility options need to be put forward, like adoption and other modes of IVF. In our other unit, under Dr. Mani Murli, we did a patient who was a 15-year-old stage 4 choriocarcinoma with brain mets, liver mets. And this patient was HIV positive, low CD4 count, high viral load. So she had a metastasis to the vagina, which is stage 3, and it eroded into the uterine artery. So she actually bled while she was in the D ward wing in Albert. And it was a severe obstetric hemorrhage because the HB was like 2 unrecordable. So we transfused her, massive resuscitation, and proceeded to attempt a uterine artery embolization. So the uterine artery embolization, by the time we got the patient to an HB of 9 to 10, was successful, but it was successful only for about 16 hours. And vaginal packing was done in this patient. So she was put in the high care and she was stabilized because of her age, because she desired fertility, and we had the issue of low CD4 count. So this patient here, basically, the next day, she was stable overnight, and then the uterine artery embolization gave way, and she started having severe obstetric hemorrhage again. So it was the first patient that we had to do a internal iliac artery ligation via laparotomy, and we had a very good outcome with that. And then the patient was fast-tracked to chemotherapy after she was optimized. And 6 months later, she was cured from the choreo, with cure rates over 94 to 96%. So it is possible. If you pick them early, time them, refer them to the right centers, and have these options, you can reduce the morbidity and mortality of malignant moles and invasive moles. Thank you. Is there any question? I think we'll deal with our audience here first. Any questions regarding trophoblastic disease in the presentation? Okay, there's no questions from the audience. Anybody online has got any experiences or any comments regarding the presentation?
Terence, can I make a comment?
Yes.
Yeah. Thank you for that presentation. Firstly, is that I see you repeatedly use the terminology obstetric hemorrhage. Now, is gestational trophoblastic disease regarded as part of obstetrics? Because why I ask this question is when it comes into patients demising, and we have, as you know, with maternal deaths, it's a process that we need to put into forms. Now, we don't include these cases. That's the first thing. So the cases that you're saying where you're getting hemorrhage, and I accept that, and where there's heavily bleeding and patients undergoing surgical intervention and demising, is that obstetric hemorrhage? It's the first one. The second is you again say that surgery, when you talk of surgery in these issues, you say there's limited role. But up front, it is very clear, and this was presented, that with molar pregnancy, your mainstay of therapy is still evacuation, which is surgery. So certainly, surgery is important. I mean, we're talking surgery, and I don't know whether you're equating surgery with hysterectomy. So surgery, to me, plays an important role. And thirdly is that in elderly patients, you know, when they were above the age of 45, completed family, and they came with molar pregnancies, and where we found the chest x-rays were negative, that means where investigations didn't suggest that it was so-called extended disease or advanced stage disease or higher staging as you identified, we went in to do hysterectomies on those patients. Is that the correct thing? I'm talking about elderly patients now. As primary as compared to subjecting them to a suction. And then, yeah, maybe you can just answer those 3 questions.
I'll start with the last question of a 45 years old that comes with a GTN. I think that's where the role of surgery will have to come in because, I mean, it's a patient that has completed family and yeah, so why put the patient through these HCG monitoring and follow up when you can just opt for surgery? So in these patients, it would be indicated. And then the first question about it being an obstetric hemorrhage.
Yeah, I'll take that question. When we went obstetric hemorrhage, we went bleeding from molar pregnancy. We didn't mean pregnancy and bleeding as PPH. The surgical aspect, we're talking more about hysterectomy and not suction. Though suction is the first line management option. So most people do suction for them. We won't take a full molar pregnancy of 16 weeks size and bleeding risk and then do a hysterectomy upfront. Unless she's got rising beta HCG values, and if the transvaginal scan is showing there is evidence of invasion, then we would rather opt, especially the invasive mode, as an elective hysterectomy option for a patient who's 45 years and above. She's already completed a family, then she's a good candidate. That's where the surgery has a role in terms of elective surgery. Any other questions?
So I just want to make one more comment. You know, our previous head of our department, that is Professor Green Thompson, Randolph's uncle, wrote a very beautiful article in the Ballius Clinic on the surgical approach to gestational trophoblastic disease. It must have been, it's an older article, you know, it's in 1997. I still have the Ballius Clinic on that. But it, you know, it tells you the surgical options, although it is old, is what we had done in King Edward, and not much has changed in terms of surgery, radiotherapy, involving multidisciplinary teams, etc. So it's good if the registrars could get a copy of that. Although old, I think it gives you very good guidelines.
Correct. We use that article, and it's an important article. I mean, it's the first article that was written on surgical or surgery in actually trophoblastic disease. Any other questions online? Okay, if there's no further, okay. There's a question.
Thank you for your nice talk. Just wanted to make a comment on patients that are on induction chemo. Let's see, as she rightfully mentioned, that some of patients with ultra high risk, you actually want to give them something gentle, like a general chemo, before you put them on that full IMAC or IMAIP. I've managed some of those patients now that usually come in other organ dysfunction, maybe cardiac complications from the direct toxicosis, that are other issues, and they are really unstable for you to just start on this IMAIP. So that's play a huge role. You should start them with that soft induction chemo to release the negative level.
Thank you for that. Yeah, the high risk, ultra high risk disease has a high mortality. So you got to look at all the other underlying medical and other risk factors. Is there any further questions?
Terence, there's one more question. Look like nobody wants to ask.
Okay, Dr. Alba.
Yeah, the one that troubled us was patients who we made the diagnosis of molar pregnancies, but the cervix was firm and unyielding. So we were always afraid, you know, to dilate those patients. Then came the issue about using some form of cervical ripening agent. And they told us, hey, no, you couldn't. Those days we used misoprostol. Not misoprostol. We used prostaglandin. Yeah, Prostin E2 tablets and all. That told us, no, that was a contraindication because we couldn't control the uterine activity. Is there anything or any advice you can give if you want to embark on a suction, but your cervix is not, or put it this way, the cervix is closed?
Yes, when you looked at the literature actually doesn't advise that because of the risks with your cytotech pre-cervical ripening and your prostaglandins. But we have done them previously. We should say normally the cervix is unfavorable when you actually dilation is the only way to get to suction curettage. But we used clinically on the floor cervical ripening agent, maybe a cytotech, but under consultant guidance. Put it in the morning and then came and saw the patient and then took the patient to theatre. But because of the hemorrhage and the risks for rupture, the literature says otherwise. They basically avoid the use of pre-cervical ripening agents. And the only way they look at it is dilation and suction curettage. But the problem, I take that point that when you go there, if you've got a hard cervix, what do you do? Because the risk of perforation then is higher. So we've used previously, I mean, at 6 o'clock in the morning, put in a cytotech, the patient is booked electively till 8, and then a short course softens the cervix, and then you go and dilate under control conditions.
Thanks, Terence. And where's our oncology team?
I don't see anybody here. I wanted to ask online.
Dr. Maraj or Dr. Mold is not around.
Yeah,
I'm
maybe
in
I'll
here,
ask.
Doctor.
Oh, okay,
Ask
Dr.
the views.
Atisha Maraj may comment on some aspects. I didn't know she was online. Okay.
Yeah, so well done, Dr. Mahdi. I thought it was very good talk, covered all the aspects. Well done on that part. Coming to your questions and comments regarding the surgical aspects of it. Starting off, nowadays, you can use cytotech, as Terence mentioned, if you give it at 6 o'clock in the morning, and it must not be given the night before. So essentially, it's just soften it enough to allow dilatation. So previously, it was not recommended, but nowadays you can use it provided it's not more than 6 hours in between insertion and dilation of the cervix. Yeah, so they do use that now. Regarding the hysterectomy part for patients over the age of 45, it's something that's not, I know previously that used to be your first line because they've completed their families, but it must be undertaken with the proper discussion with the patient because there is still significant morbidity that can occur due to the vascular changes associated with a molar pregnancy. If the patient opts for it and agrees to undertake the risk, that's fine, provided they understand, but it's not generally our first line at the time. If they do have a suction and they have a rise in beta HCGs, then yes, as a second line surgical option, but not as an upfront first line option. So that's my input for those.
Yeah, the other aspect of it is that, in terms of follow-up of those patients, I think the registrar made mention that there is less surveillance, but that's not true. I think the way you would monitor these patients post-surgically is the same as if you did a suction.
Yes, that's correct.
Yeah, because although there's less likelihood of persistent disease, but you still have to monitor them.
You have to follow them up. Yes, correct.
Okay, thanks for that. Is there any further questions or comments? If there's none, I'd like to thank everybody for attending and thank Dr. Mahdi for a well-presented topic. Thank you.
Recording stopped.